All right. So it is my pleasure to introduce today's speaker, Dr. Elizabeth McKinley. Dr. McKinley is an assistant professor in the College of Nursing at the University of Cincinnati. Her research focuses on assessing environmental and occupational exposures in healthcare and home healthcare settings that may impact health outcomes, with particular expertise in respiratory exposures, blood-borne pathogens, and infectious diseases. Following her doctoral training, Dr. McKinley completed her postdoctoral fellowship in the Division of Biostatistics and Epidemiology at the Cincinnati Children's Hospital Medicine Center, where she continues to collaborate on environmental health assessment projects. Today, Dr. McKinley will be presenting occupational and environmental hazards in pediatric home healthcare with steps towards simplifying the data collection tool and process. So please join me in welcoming Dr. Elizabeth McKinley.
Thanks, Alyssa. When you say that I'm an expert in anything, I'm like, well, that's generous. But I will say, when you mentioned about infection prevention, infection control, that is probably my strongest interest, my biggest passion, because I worked in the operating room for so long. That is a completely controlled environment for the most part. And we're constantly looking at what's clean, what's dirty. When I moved into the role of an infection preventionist, I continued to look at what's clean, what's dirty, how are we impacting both the worker and the patient at the same time, which then led me to get my master's in occupational health nursing. And I really am glad that the ERC at the time was their research focus targeted research training program was all focused on the home environment and the workers that enter that home environment. It's funny when I have talked about when I have compared the home environment to the what I consider the controlled environment of acute care. People who look primarily at acute care are like, what do you mean it's controlled? Like it's chaotic sometimes. But it's controlled compared to what we have control of over in the home care environment, in the home healthcare environment. So as you said, during my postdoc, I was uh, a fellow in the Department of Biostats and Epidemiology, and they had an employee safety learning lab. And our learning lab was the healthcare environment, not a lab such as a bench lab. And we really started to think about what happens in that pediatric home care environment. So I'll go ahead and get started with my slides. I just wanted to give you a background of kind of where I'm coming from and how this all evolved and how I evolved into this, what you call expertise. Um, so the information that I'm going to share with you today is based on a project that we started when I was at uh, in my postdoc fellowship. And we had a manuscript recently accepted for publication. It's not all the way out, or I would have given you the DOI. And this was a award. The award came from the CCTST, and of course, we went through human subjects review. So a little overview of the population of home healthcare workers. There's currently 1.4 million US home healthcare workers, and they provide home care services within the patient's home. And these services have expanded with Medicaid coverage increasing. It also is increasing the demand for workers. Within the population of home healthcare workers, there are two separate types of workers. One, which I refer to as licensed healthcare workers. I do not like the term of skilled and unskilled. I feel like unskilled is doesn't align with my belief of that they're extremely skilled in what they do, but they are unlicensed. So the licensed healthcare workers in home care home healthcare worker population, they're typically nurses, physical therapist, speech therapist, occupational therapist, massage therapist, and respiratory therapist. All of those have a license through either a medical board or a nursing board. There is another group of workers in this population, and that's the unlicensed workers. These are home healthcare aides, also sometimes referred to as nursing assistants. Um, and they help with activities of daily living. Some of them are giving medications. They have a certain certificate for that. Um, but these workers are typically not doing tasks such as um, ventilation settings, drawing lines, taking care of IV lines, taking care of feeding tubes or ventilators. These workers are typically doing things such as bathing, helping the patient with cleaning of their home, feeding the patient. Um, but while these workers have different tasks, they be different exposures because of the different tasks that they have. They do have similar exposures because they're all entering that home of a patient, which is not controlled at all. And let me describe what I mean by controlled. In the acute care setting, we know the number of air exchanges that are occurring. We have to meet certain standards for certain departments of the number of air exchanges that are occurring. We have to have air blowing in a certain direction, and exhausted in a certain way. We know what cleaning materials are used. We've educated on the cleaning materials. We know what medical equipment is used, and we've educated on the medical equipment. In addition, a lot of times we will know what workers as well as what visitors are coming and going in that environment. Whereas in the home care environment, we're not controlling the cleaning materials that they're using. We're not controlling how often something's being cleaned. We're not controlling the air, and we have no control of who is in that home. So the pediatric home care population, it's growing. And that's due to the expansion of insurance coverage for this care and the improvements in medical technology that's increasing the number of complex care patients that can be cared for in their home. In 2022, there were over 41,000 pediatric patients enrolled in Medicaid and that received home care services. The next two bullet points are the type of services that they received, and there were of those 41,000, around half of them have chronic conditions that require care for more than 12 months at a time. A lot of these chronic conditions are provided care for the life of the patient. And as you can imagine, because our technology has improved, the life of the patient improves, and the need for persons that can care for that technology in the home, it's needed. In 2016, the American Academy of Pediatrics indicated that over 500,000 pediatric patients receive some type of in-home healthcare services. So as you can see, we do have quite a bit of pediatric patients that are being cared for in their home in some aspect. So as I've said, the home care environment is unregulated and it's variable. It's as unique as each of our own homes. The known risk are sharps injuries, secondhand smoke, unsafe lifting, environmental hazards, blood, saliva, respiratory secretions, pets, violence, cleaning materials, as well as slip, trips, and fall hazards that are within the home. Again, that whole idea of slip, trip, and fall hazards and the pets in the healthcare environment I had worked in there for 16 years in the acute care setting. We design rooms based on where a plug's going to be. We design rooms and things that are all on the wall based on where we want needle boxes to be as well as glove boxes to be. And we also consider where our cords are rolling across or pulled across the floor, and in the home we have none of that. So I did do a quick literature review before this presentation and did find a couple of things that I wanted to share. The first two articles on here talk about the turnover rates and indicate that since 2016, the turnover rates in home healthcare have been rising. And the reason for that is that the wages in home care are actually not keeping up with the wages in other care settings, such as long-term care. So what they're seeing is these workers that are trying to chase, a living wage, and a lot of times they're working multiple part-time jobs to be able to provide for their family. And sometimes those jobs do not have benefits, but they're going from place to place to get a better wage. Which is likely what all of us think about sometimes or have at some time in our life and in our career. Um, the last one is related to mental health and stress. And the thing I really liked about this study, and I'm actually sad that I didn't see it for another paper that I wrote. This was a qualitative study, and there were 28 home healthcare assistants that were the participants. 61% of them spoke Spanish. We do not see that large of a Spanish speaking population in a lot of our studies, and I was glad to see that here. The other thing that was different with this study is that their mean age of the participants was 26, and that is lower than what we typically see as the mean age of the late 40s, early 50s in-home healthcare workers. What the study found was that the attitudes towards mental health and well-being for these workers were influenced by a variety of personal and cultural factors, and their relationship with their patients impacted their mood. And what they described is that it impacted their mood both positively and negatively. Oftentimes in previous studies, we've seen that home healthcare workers really like that they get to know and they seem to be part of the family of the families that they're caring for. One thing that they mentioned is that home healthcare assistants used a variety of strategies to cope with their emotions, and they are eager for interventions that can improve their mood, particularly those that bring them closer to their colleagues. As most of us, I think, are either in an office by ourselves or at home by ourselves, in your home office or at your kitchen table or at your couch. Um, we're isolated, and these workers are also isolated. These workers drive in a car by themselves. They show up to work by themselves in the patient's home. And sometimes when you have a patient that things aren't going well with, you're still by yourself. You're not being able to call down a hallway as you do in the acute care environment and bring somebody to help you. You don't have a worker that's down the hallway that you can vent to. So I think it's great that this study has been done, and that they've pointed out the interventions that the workers are actually desiring. So limitations on previous studies, and specifically the previous studies that I mentioned in the article, is that it was primarily focused on adult home care. So adults who are living in their home and receiving care. Primarily, the participants of the previous studies were the workers who cared for an adult in an adult home. We relied on retrospective recall, and there's a lot of bias with that. There were no known standardized tools specific to pediatric environments, and we also had no real-time hazard identification that I could find in the literature. So the reason for this work is in response to our previous work. While we're all on our own journey as researchers, I too am on my journey as a researcher. And I like a lot of information. It's probably why I liked being in the ICU and in the operating room. I got to always focus on one patient at a time and really look at all of their care and all of their health information. So during my postdoc, I didn't tell you what that tool was. The home healthcare worker observation tool was developed, and it consisted of over 600 items, and they were divided into topics and multiple choice, and they allowed for an observer to you tried to quickly document 600 items and keep track of, did you document this? Did you document that? And not look at your paper and make sure that you're getting everything, right? We can all see the issues with the tool that I developed at the beginning of my journey. Um, but we were really looking at what were the risks to the home healthcare workers. And also, I included some risks that were overlapping, and most of these risks are overlapping of risks that are patient specific and worker specific. We did content validity by experts on that tool, as well as inter-rater agreement. The tool was not mobile friendly. It required an observer to be in the home care visit. Um, to highlight what that means is that if you are in the middle of a pandemic and you're trying to do this study and you have home healthcare workers lined up that you are going to follow into a patient home, you are no longer able to carry on that study and collect that data because you're not able to go into that home because you're now an additional exposure risk to that patient. The other issue was there's 600 items. The tool, the home healthcare worker observation tool, has been used in the United States as well as Puerto Rico and UK. And we did have some really great learnings. I helped with the data collection and leading of that project in Puerto Rico. We had some great learnings about how we were actually carrying out this study and how we engaged with our workers that then we were able to engage with in the home with the patient. So what we transitioned to was the home healthcare environmental assessment survey. It is a survey that is done in the pediatric home care environment, and it identified environmental and occupational exposures encountered by home healthcare workers. We took 600 items and we got them down to 30 or 40. I don't know why don't have it on this slide. I want to say there's 32. But and we were also able to put that on REDCap, and the worker was able to go through that home healthcare environmental assessment survey directly after their patient visit. So we decreased the risk of recall bias. And we've also added to it exposures that are specific to the pediatric home environment. The other thing with this project is we identified a tool that was acceptable and usable by pediatric home healthcare workers. It was a two-phase study. We did focus groups. In those focus groups, and I did find out on the next slide, there's 31 questions. In the two-phase study, we did focus groups first, and I met with pediatric home healthcare workers. I listened to them talk about what their hazards are, and there were hazards that we noticed were not in those 600, those other 600 items. A couple of them were, there's a lot of incense that's being burned in their environment. Pets are often in their workspace. And the other thing that was not on my radar at all is that they are working with pediatrics. They're getting on the floor and doing a lot of their care. So whether they're getting on the floor and accessing an IV line, or getting on the floor and doing the physical therapy, the occupational therapy, the speech therapy with a small child, they're on the floor, and that creates ergonomic risk that were not on that previous survey or observation tool. The setting was a Midwest Pediatric Home Healthcare Agency, and they were able to collect the data immediately after the patient visit. We adapted the 600 item home healthcare worker observation tool, and we reduced it to 31 items that they could do on their iPhone, any phone, and complete it on in REDCap. The tool captured environmental hazards, worker practices being, did they have their needle box right where they were working, or were they carrying a dirty needle across the room? And it was designed to really reduce recall bias. Our participant sample for these surveys was 24 home healthcare workers participated in 60 home visits. 90% of our participants were female and 77% were Caucasian. They were mostly nurses. This particular home care agency that we partnered with um, does not strongly use home healthcare assistants. So these were mainly nurses. There were some occupational therapists, some speech therapists that did participate. They went into primarily suburban homes, and they were primarily single family residents, and their mean visit was 2.1 hours. The respiratory exposures that they saw were dogs, incense or candles that were being burned, cooking odors, and dust. In addition, there was tobacco smoke that was noted, and we asked them to note, was the smoking outside or was it inside? We do recognize that if somebody smokes outside, they are still bringing some of that tobacco smoke back into the home, and it's we typically refer to that as third-hand tobacco smoke exposure because it lays on the surfaces, covers clothing, and just gets in your house. So you're not smoking it, somebody's not standing there smoking next to you. For slip, trips, and fall hazards, they noted there was cords and tubing, yes, tubing, and there was also cluttered walkways. Again, when we think of the acute care environment, there are rules that you have to have hallways a certain width, and if you park a bed in that hallway, the width of that hallway is now decreased. We have no control over the furniture that's in the home or boxes or anything else. Toys. They also had throw rugs and pets in the home. Of the 50% of pets that were in the home, 51% of those were not secured away from the worker. If you can think about a small dog or large dog that is at the worker's feet, there's a trip exposure there as well as it's a wild animal, and how are they going to react if there is something that a worker or patient does that they don't like? So we've also have a risk of bite there too, as well as for somebody that may have potential allergies. So again, we can see the overlap of why these hazards are both worker and patient safety concerns. So for those ergonomic risks, we found out that 22% of those visits of the 60 homes, the workers worked on the floor. Again, had we not asked that question, had we not found that out during those focus groups, we would have missed that entirely. And I do wonder when I see these positions of kneeling, squatting, sitting on the floor, I think of more of hip and knee injuries. As well as you're also, when I think about indoor air quality, you're also closer to if you're in a on a carpet and you're stirring up carpet, what then is flying into the air? The other thing we found out that is seen in other previous data is assisted devices were not used or underutilized. Sharps containers were in the immediate area of the worker 18% of the time. I do kind of wonder about that number, and I wonder if that was actually classified correctly. So that would be one item that would really be helpful to understand by having a worker in that environment, I'm sorry, an observer in the environment and the worker reporting the same thing. Do they actually classify immediate workspace the same? Oddly, they always said that a garbage bag was present. Again, that goes back to what's present. Was it in the kitchen? Was it right there next to you working? And they used hand sanitizer. It was available 98% of the time. So what we found out that hazards were common but often under-recognized. And they were under-recognized in the sense of we didn't know this prior to making this tool, including pediatric exposures that they see primarily in pediatric home environments. And we weren't counting them previously. I also expressed that they're often working on the floor and they're also often working in improvised medical environments. We also see that in adult care. So, implications for practice. We'd love to see the home healthcare environmental assessment survey or similar tools improved, validated for use, and then hopefully used more often so that workers have an idea of what their exposures are and employers have an idea of what their exposures are so they can better protect their workers. So our limitations is it was a small sample size. It was a single home healthcare agency in the Midwest, and it has limited generalizability. This tool does need validity and reliability testing, and what we think that that would look like would be a home healthcare worker completing the home healthcare evaluation assessment survey, and the observer completing the home healthcare worker observation tool. I'd have to discuss that a little further. Do we want the same tool or do we not want the same tool? And if anybody has any feedback, I'd love it. Because these items are some represented on here, but we added the pediatric items. So ideally, design-wise, we'd want it to be the same tool. I answered my own question. So our conclusion is that pediatric home healthcare workers face a multitude of hazards, and the home healthcare environmental assessment survey adds a practical value, and we can use it. In our future work, we want to combine objective measures. So potentially putting on an indoor air quality, having that worker carry an indoor air quality monitor, or putting on some monitors that are looking at doing an ergonomic assessment for us to look at trunk bending or length of time that they're standing or pushing, pulling, anything else that may be of concern for our workers, our home healthcare workers. We'd also like to expand our sample and our geographic diversity for using the home healthcare environmental assessment survey. I would love to have an opportunity to go back to Puerto Rico and train our workers on this. We would absolutely have to make the tool appropriate to their language and their culture, and that's able to be done. So those are just some interest in some next steps. That's it for my presentation. I will stop sharing my screen and we can chat.
All right, we can open up to some questions or discussion. If you have any questions, feel free to unmute yourself, or you can put them in the chat or the Q&A box down at the bottom of the screen.
You've done a great job.
Thanks, Dr. Bhattacharya.
The question I have is, are you going to do this study locally, or are you going to go to Puerto Rico?
So this study has already been done locally. And yes, I would love to do it in Puerto Rico. Our partner down there has since retired. Her retirement looks a little differently than what I think of as retirement because she's still working on some NIOSH studies and even putting in grants. So yes, that would be something that I'd absolutely be interested in talking with Kermit about further. Kermit and I worked on the project in Puerto Rico, so I'd love to move that idea forward.
What sensors you want to use?
What sensors?
What sensors for ergonomic evaluation?
Well, I don't know. I think I'd go to the expert on the sensors. I'd ask you, and I'd probably say, hey, don't the ones that Amor was using, are those available? So if there are easier sensors to use in a home care environment, that's what we would prefer to do. I know the ones that Amor did were more of in a lab setting, so those aren't sensors that I'm familiar with, but I know that you could coach me on those.
Hello.
Hi, Kofi.
Yeah, okay. Thanks for your presentation. I love it. On one of your slides, you did mention of respirable exposures, and I saw one of the point as dogs. I want to know what really was related to that point as to respirable exposures.
Yeah, so they're carrying dander, and if our workers have any type of dog allergy, that's an extra exposure. And I think of that as an exposure that's specific to the home and not the acute care setting. So not only do they carry their dog dander, I think of my child who had a soy allergy, and every time she went to my dad's house, who lived on a farm where soybeans were being farmed, and the dogs often love to run through the soybeans because it's soft, and they'd run through it and they'd come out, and she'd come home sick every time. So whatever dog dander can carry are the respiratory exposures that I think of.
Okay.
There are some studies that say that dogs are actually, our pets are actually, dogs specifically, not cats, are actually more of a mitigation of health. That's not the right word. Not moderator. It helps, it actually improves our health. They actually improve our health. So while I recognize that there are some benefits to pets, I also recognize there are allergies that if I was a home healthcare worker and I don't have a pet in my home because I'm allergic to that, a dog or a cat or birds or whatever, if I have that in my work environment, it's not something that I can actually control.
Okay. Thank you.
Mhm. And Kofi, maybe respiratory is not the accurate word, but I would argue with that.
Yeah.
It's an upper respiratory, right? Because dog dander is so heavy, it's going to hopefully get stuck in our upper respiratory system, and it's
Yes.
going to be respirable down to those smaller, fill in the word, little sacs, air exchange.
Okay.
You know what I'm saying?
Alveoli?
Yes, yes. Thanks.
Okay. I get it. Thank you.
Thanks for the trivia.
Thank you.
Well, if we have no other questions, thank you all for joining us for today's webinar. And
Yeah,
thank you
thanks for your
again.
time.
Yeah, and thank you again to our speaker, Dr. Elizabeth McKinley. Following this webinar, there will be a survey sent out. If you are requesting CE credit for this webinar, you will need to fill out that evaluation to receive your certificate. And that's all for today. Thank you all for joining. Thank you to our
Thanks,
speaker.
everyone.
Thank you, everyone. Thank you.